Okay, my name is Prossy. I work with the National Health Laboratory and Diagnostics Services, Ministry of Health, Uganda. I have been in the laboratory for now 9 years. So I have become a real laboratorian. And everything that I do, I have learned from the lab in Uganda. When we were starting laboratory information systems in the country, we had a lot of consultations from the laboratorians. So everything that we do and implement is from the laboratorians in this country. So many of the people here know that they were the contributors of the Uganda Lab Information Systems Master Plan using the enterprise architecture approach, and that's what we do up to today. So the laboratory information systems that we implement is made in Uganda by the Ugandans, for the Ugandan people, and the rest of Africa. So I will focus on the current topic today, and that is integrating ICT in the COVID-19 outbreak. The outbreak of coronavirus in 2019 led to integration of information technology for the timely response of the pandemic. The PCR centralized laboratory investigation of the severe acute SARS-CoV-2 virus necessitated an efficient transportation of specimens to the testing laboratory and mechanisms for immediate reporting of results to identify, manage, and trace contacts. In Uganda, in the beginning, we had only one laboratory that was testing for SARS-CoV-19, and over time, as we speak right now, we have about 80 PCR labs that have the capacity to test for COVID-19. That is both public and private. Yeah, outbreaks can overwhelm weak or fragile health systems that lack easily adaptable tools and infrastructure. I think Rufus was able to make a comment on this. So timely detection, preparedness, appropriate response, and prompt reporting are essential for limiting both the loss of human life and crippling the socio-economic impact of any pandemic. To integrate ICT, to define the information needs for the response, so we had data flow diagrams that we used to graphically represent the flow of data to show the logical scope of existing information systems in the disease outbreaks. In Uganda, we do a lot of innovations. So almost every program in this country for lab or health has its own system. So we have quite a number of electronic information systems in the country. So we had to come up with a logical data flow diagram describing the process that are involved in the response to collect and transfer data from rumors or an alert or case notification, then sample collection, transportation to the testing laboratory, result reporting, case identification, and management to contact tracing. So all these needed to be either digitalized or integrated, if they are already electronic, integrated into the response. To identify resources in the information management for the different processes towards achieving the integrated response system, stakeholder mapping and engagement is very important for the defined processes because they are different players, together with existing system implementers and users in the country, in the health space. That was done. Then ICT enabled timely reporting and access to laboratory test results, case identification and management, contact tracing, and cross-border travel, as mentioned earlier. This should be the strategy for health services provision, actually, in the region So that was the data flow diagram. We had to sit down and first understand who are the players, what tools are there, how do samples flow, where do they come from, how do they end up, and what is the final result. After we have done the testing, we have managed the case, if it is the result of death or the result of someone that has left the isolation unit, and we were looking at a big visualization or data aggregation dashboard, which you already have. So I am speaking here on behalf of the laboratory, which I do manage, but I was also working as the vice chairperson for the strategic information and research pillar for the incident management team. So that's why we were looking at all the data components, and we came up with that data flow diagram for the country to be able to integrate all the necessary data flow pieces, both digital and paper. Then I focus now on lab information management. We had a data tool which was changed. I think the last one was about version 4.0, because there was a case investigation form for the outbreaks, general outbreaks. Then it kept refining until we came up with one, which is the same that we are also digitalizing. Later on, you realize that you could not go to another country unless you have a COVID-19 test result. Now we are talking of a certificate, which is also another digitalization component that we had to do. So you can go to the health portal and you put in your identifier with your telephone number, and then you download your certificate. So currently, that is where the COVID-19 is. So we're looking at electronic data capture, and then visibility of lab data, and also we have a warehouse for laboratory information systems, but also talking about integration of all kinds of systems in the health sector, and specifically here, laboratory data. So this is how, simply graphically representing, I said we have about 80 laboratories that can do PCR testing, leave alone RDTs, those that can do PCR testing. So each lab would have individual access to upload results into that centralized portal. In Uganda, we call it results dispatch system. And then the different users of the results would have access into the RDS and download the data and use it for managing cases. As we went on, we realized there is a risk of security. I think COVID-19 became also another money-making venture, and yeah, the sharp people were also misusing it. So we had to increase the security of access to the system. So you have a two-level authentication. If you're to log in, your username has to link with your email address, and for you to proceed, you have to get a token from your email, which you input, and then you can be able to access the actual results or upload the data. So that was, we kept working as things kept, as the environment kept changing, we also kept on adjusting. And I think, like I mentioned, when you have a local team, it is much more easier. So currently, as we speak, we are using the same infrastructure to put together the Ebola response system, which we have already finished, just asking the reference laboratory to be able to upload the results and then give access to those that on the need-to-know basis to access those results. So we are using the same infrastructure, and this infrastructure is what we have used for before for HIV management. All the HIV for viral load and early infant diagnosis initially was centralized, but results needed to go back to the patients out of the centralized laboratory. So it is the same infrastructure that we've been building on, and we are looking at having this as our outbreak response information system for results dispatch. So as the need increased, we had RDT testing as the algorithms kept changing, so even the scope of ICT had to change. So we came up with a mobile application where if you are up country or in a health center 2, health center 3, and you're testing, you can just log in, access the result, access the application, put in your information, and upload the result. I think my next project is to be able to scan using the camera to read the result, and I just upload so you don't have to enter. That is the next innovation that I would like to dive into. I think I've got the revelation when I'm standing here. The reasons for success or the achievements, of course, the improved turnaround time. Initially, the results will take forever to get to the requester. Faster case management, we have a specific access to the team that was managing cases in the ICUs. So it was easy for them to just get in, pick the results, and manage that first and second and third before they could discharge. Quick adoption of the users due to the familiar HIV system that I mentioned, security and confidentiality of patient results, and the other success factor is local or in-house software developers. It is easy to change as the environment changing. And then we are also privileged as the Ministry of Health to have a high capacity data center for hosting information systems. So it is easy, we don't have to look for where to host our systems. We can host them locally. Mine has acknowledgement of Ministry of Health, staff of NHLDS, the CDC has supported us a lot, UNICEF and Global Fund have been part of our support. How do we do it? Identify the user needs, develop and deploy apps, test and retest and test and retest. We keep improving, and we use open source applications coupled with in-house development, but of course you need funding, like I need to be paid a salary, and the people that I work with, the hosting environment, the internet, if we are to distribute results across the country. So that has helped us to keep improving over and over. And we also, of course, thank the users. The time when I joined the laboratory, I said it's now 9 years. It was hard to introduce a computer in the laboratory. But today, all the lab cadres, can we clap for ourselves? We have really moved. And that is a milestone. Now everybody says, I need a computer. We move with our tabs, we move with our computers, and we have internet, and we have really improved. That is very, very big a milestone. I want to thank you so much for listening. You said 5 minutes. I guess I am under 5. Thank you.
I understand there's quite a number of laboratory information systems in Uganda. And I just wanted to know, as CPHL, is there any possibility of integrating those systems for, to determine, say, some disease prevalences, or to be able to manage the information, the laboratory information system in Uganda?
Thank you so much.
Okay.
Yes, I actually mentioned that in Uganda we actually do a lot of innovations. I think as we speak right now, there are already people that are innovating Ebola or monkeypox related systems. But I mentioned that we try to take the integration model where we are not saying we agree that we use this system or use the other system. We only want to include everybody by integrating. And as a country, health informatics, we are actually doing the program of health information exchange, where we have several systems speaking to each other, most importantly for us to ensure that the information or the data that is collected can be used, can be accessible. But in most cases, data is collected. Actually, I think in the beginning of the pandemic, for example, you would not know how many people visited private facilities and they had their tests done and probably ended up dying or not dying. But at the end of the day, when the ministry said that we need all COVID-related information into one place, it was easier. Some of the private laboratories had their laboratory information systems, and a few of them we have actually worked on integration using health information exchange, and they are sharing data directly from their LIMS into the Ministry of Health LIMS. So if any laboratory has their information system or lab information system, the CPHL, like the question was, is very ready to work with that laboratory and ensure that we integrate. At the end of the day, from the ministry perspective, we are looking at, we want to know what is happening everywhere. And private sector would be very much interested, because in public, it seems to be easy, but in private sector, we are very interested. So why we started with CSV uploads is because we needed to make it easier and faster. But we are happy to work with any laboratory and ensure that all this data is integrated. And we are progressing on that side of health information exchange, that is HIE. We have the lab information system exchanging with health management information, hospital management information systems, and the data is clearly flowing and we can be able to visualize it. Thank you.